providing awesome CDT and home care in 30 minutes. Let's see if I can charge you up. First of all, it's my turn to find out, take my round of who's in here that does home care. Who are my home care therapists? More than I thought. That's awesome. So, good. I feel like there's a whole new world out there that we don't get to talk about a lot, and that would be home care. I love home care, but there's a lot of what I think is opportunity. So let's move right into it. So do these patients look familiar to you? Have you seen these patients before? Do they have lymphedema? Would you say, how many say yes, these patients have lymphedema? I say they have lymphedema. But what's interesting is all these patients have phlebo-lymphedema. And that is a game changer, especially in the home care setting. And how about these patients? We've all seen these patients, right? Some of these patients could be homebound. Some of these patients are coming to you in outpatient, and some of them could be homebound. Homebound doesn't mean you're stuck in bed. Homebound just means you have a hard time getting out of your house. You can still go to your doctor's appointments. Just because you can make it to the doctor doesn't mean you're not homebound. If you look at this picture here with that walker, and, a lot of these patients are coming to you with walkers, they're having a hard time getting in and out of the car. Someone's probably driving them to come and see you. They can still go to the grocery store. These patients aren't bedbound, but they definitely could be homebound. So that's a whole lot of people, a whole lot more people than you might have thought, or a lot of people might have thought. So I like to get that out of the way first, so just to kind of establish what homebound actually means. So yes, my name's Bryan Groleau. I live in St. Augustine, Florida. I've been a lymphedema therapist for 15 years. And I spent 8 years in the home care setting, and I spent a lot of time in management. I started a lymphedema wound care program in the home care setting. And basically, in a nutshell, I went to the owners of the home care company. I said, I really want to do lymphedema. And they said, we want you to do lymphedema. But here are your confines. If you want to do lymphedema, you got to figure this out. Here's how much money, and here's how many visits you got, and if you can figure that out, go for it. So for me, it was kind of like I said, opportunity. If I don't figure this out, these patients aren't going to get seen, because a lot of them cannot make it to see you in the outpatient settings. So if I don't figure this out, these patients aren't going to get seen. So that was kind of what really, thank you. That's really what geared me up to want to do home care and figure this out and make a program that could actually work and provide awesome CDT in home care. So a couple disclosures. I am a full-time employee of Medi USA. I'm an educator. That's what I do. Educate on lymphedema and wound care. I also am on the Medi for Help team. And basically, in a nutshell on that, I am able to go to Haiti and work with the lymphatic filariasis clinic there, and as well as provide education to the college that started a couple years ago in Leogane, Haiti, to provide wound care education and lymphedema education. So I'd love, if you want to know more about that, please come and see me after, and I'd love to talk about it. It's been a great journey, opportunity. I've learned so much from it. So I want to throw some statistics at you, just some numbers. As you know, statistics and numbers, and all these numbers are usually a few years behind. So what I'm reporting on is basically from 2017. But this is how many Medicare beneficiaries there are in 2017, 57,700,000. In 30 years, look at that number, look at the jump. It's not going to double, but it's probably going to go 75% growth of how many Medicare beneficiaries there are. How old do you have to be on Medicare? 65.
Sorry, I can't search the web on it.
Apple doesn't even know how to answer that. Thank you, Siri. I always thought she was useless. No offense. She never helps me. So we have a huge growth pattern here. I'm glad I got you laughing. And this represents where do patients go from post-acute? Where are they leaving that hospital from? And if you look, 20% are going to home care, 22% to skilled nursing facility. 48% of these people aren't getting post-acute care. So the majority of these people are going into home care and skilled nursing, the other long-term care facilities, inpatient rehab facilities, and hospice. So 20% is huge. How many Medicare beneficiaries do we have? What's the growth pattern? And how old do you have to be on Medicare? So you see where I'm headed with this? We've got a lot of patients that are going to be going into home care. And the majority of you in the room are not home care therapists. So hopefully I can make a few more of you by the end of this, now 20 minutes. This is not a huge spike. This is 1 year to another of how many admissions there were in home care. 20,000, that's not that significant of a number. However, I guarantee you that number's not going down. And if you want to add 25,000 admissions every single year and add 30 years to that, you can do the math. And I have a feeling that number is going to speed up as well. So my point is, things are growing. So I like to look at our country and kind of go over some more statistics here. We've got 1 to 2 million people with primary lymphedema, 2 to 3 million with secondary lymphedema. Now, last I checked, my patient caseload was not 1 primary patient to 3 secondary patients. Is that the way it is for you? I have a lot less than this number here. My point is, we can only report on what's diagnosed. So we have a lot of phlebolymphedema out there that's probably not getting diagnosed. We have a lot of lymphedema not getting diagnosed. Hasn't that always been a problem? Exactly. My guess is this number is a lot bigger than that. We also have an obesity problem, and that's already been mentioned this morning. If you came to the class yesterday that I did, you'd know that we were talking a lot about obesity lymphedema and how that's on the rise. And the latest statistic I have for you on that is it's at 39.6% as of 2016. So we think that it's going to actually be more patients with obesity lymphedema than your cancer-related lymphedema. And that's for a few reasons. One, because we've done a good job as lymphedema therapists educating the oncologist, educating the radiologists and the surgeons to say, hey, maybe don't take all those lymph nodes out. Maybe take one out. Maybe do one lymph node dissection. Let's do biopsies. Let's start doing preventative things to make sure these people aren't getting lymphedema. So we've done an awesome job there. And so that's one reason I think obesity lymphedema is going to surpass oncology-related lymphedema. But that doesn't mean you're going to be without work, because the number one type of lymphedema in our country is phlebolymphedema. I don't know if that's new information to you. I learned lymphedema through oncology. I did not learn phlebolymphedema when I learned to become a lymphedema therapist. And this has kind of taken me a while to figure out. But like I told you, phlebolymphedema is a game changer, and it explains so much to me why, when I went into home care, 99% of my caseload is lower extremity. Here's what phlebolymphedema looks like. Bilateral, often bilateral. When you have oncology patients, are they typically bilateral? They certainly can be, but usually they're going to be unilateral. So are the primary lymphedema patients. Not that they can't be bilateral, but generally speaking, they're going to be unilateral. When you see bilateral lymphedema, look for the coloration, because this hemosiderin staining is a classic characteristic of vein disease. This is lipodermatosclerosis. We call it the inverted champagne bottle. And this is also a characteristic of late-stage vein disease. Doesn't look like much. It's not much to look at. If you want to try and pit that, it's a non-pitting edema. It's very fibrotic. It's lymphedema, straight from the vein disease. This, we know, is a lymphedema patient. But this patient also has to hemosiderin staining. He also has vein disease. We call it a fancy word, phlebolympolymphedema. Say that fast 3 times. Sometimes we add fancy words to things, but sometimes they help. This word actually helps me to identify what I'm looking at. Phlebolympolymphedema. Okay, I know he's got lymphedema, I know there's lipedema, and I also know there's vein disease. So now I know what I'm looking at. So vein disease, real quickly, basically what happens is we all know about lymphangions. Veins, they have bicuspid valves that open and close, right? They're safe valves so that nothing can fall backwards, right? Muscle contraction, fluid movement, distal to proximal. Isn't that the way it works? Right. Well, with vein disease, these bicuspid valves fail, and they can weaken. And that's actually the number one reason for vein disease is the weakening of the valves, and they call that primary chronic venous insufficiency. The other reason to get vein disease is from DVT, venous obstruction. If you've got a blood clot lodged underneath one of these flaps, it's going to cause obstruction. This is what they call secondary CVI. But the majority, 70%, have primary CVI. And that is going to lead to lymphedema. There's an estimated 10 to 15 million people that this affects, and 150,000 new reports every year. So, I'm going to give you your take-home message early, because what's the number one type of lymphedema? Phlebolymphodema. And how many people do we have with that? 10 to 15 million. That's a lot. You think they're all diagnosed as lymphedema? They don't all have lymphedema, but let's just say they do. You think they're all diagnosed? Probably not yet. We got a lot of work to do. If we can do what we did with oncology to the vascular world, to phlebology, we're going to be very busy. Let's just say that. So how many of those will turn into lymphedema patients? I couldn't give you that number, but I can tell you how many people are walking around with vein disease and what that leads to. And again, what general population of these patients are getting vein disease and phlebolymphodema? Over 65. Medicare patients. Where are these patients going? They're going into home care because their mobility is decreasing with age. And God forbid they get on one of those scooters too early, because the minute you stop mobility, let's not go down that road, right? Literally. Walk as long as you can. That's what I tell my patients. So in the home care setting, there's not that much out there to offer these lymphedema patients. So they fall through the cracks. And they've got lymphedema, but there's no one to treat them. And so they fall through those cracks until they are no longer, they've grown so much, the problems got so bad, you can't ignore it anymore. Now it's gotten so bad, we've got to do something. And so they try, and nurses go in and they do their wraps, but there's still not enough to be offered for these people. So they're falling through the cracks until they grow up like this, and there's nothing you can do. You've got to do something. At that point, they come into your hands, and that's a lot of work. So here's the dilemma for agencies out there, home care agencies. There are so many agencies. There's thousands of them. In fact, in Florida, where I live, we're not allowed to, no one can open a new home care company agency in the state of Florida right now because there's too many of them. They won't allow it. You could purchase another one that's already existing, but you cannot start a new one because it's that many agencies out there. So the dilemma is, these agencies, we know about lymphedema. The doctors know about it. They know enough about it now, but they're running away from it. They're running away from lymphedema, and they probably should be. They're probably right to do so, because lymphedema episodes are hard to control, and that's the problem. They want to do it. They want to provide this service. They need to find a therapist. They need to find a therapist who's willing to drive, but they also need to find a therapist who can understand managing the episode so you don't do too many visits, so you don't lose basically your bottom dollar. And that was what I was up against. If you don't manage the episode properly, you're going to spiral the session out of control, the episode out of control. And then, I know we've talked a lot about administrators and standing up to them, but if you don't manage it properly, you're going to lose your program. And I know a company right now that's happening with. They're contemplating doing away with their lymphedema services because of mismanagement of these episodes. So it can be done. It can be done. And I hate to see a program go, because the last thing we need is that program to go. We need more programs. We need more programs. So hopefully some of you are out there are like, yeah, I think I want to do home care. The other huge problem is the wound care that happens with this. As you saw on one of the first slides, wounds are going to occur. And those also are costly. Supply costs, it all comes out of the pocket of the home care agency. Patients don't pay for supplies. They don't pay for lymphedema wraps. And they're very difficult to discharge. This is where the episode management gets difficult, because you can't just typically, the discharge process is not typical. Oftentimes they're not able to take care of themselves, and caregivers are far and few between. And the caregivers just trying to get their daily needs taken care of, let alone the lymphedema. So it gets very tricky. But there are benefits to an agency taking on lymphedema practice. You know, these agencies, like I told you, there's so many of them, they're so competitive, they'll do anything to get a new way to get in front of a physician. This was a huge opportunity for me. I got in front of so many physicians. It's like, oh, you know, the marketer would go to the front desk and they'd say, well, we don't need to see any more home care. Well, we do lymphedema. Oh, okay, let me schedule an appointment with the doctor. So all of a sudden, it's a good opportunity for these home care agencies. There is an opportunity for them to increase their revenue. And it really gives them a competitive edge. So there are benefits to this. You can approach these home care companies with this very idea, but you also have to be ready to take on that responsibility to manage those episodes, and it totally can be done. I'm not going to be able to get into it heavily here today, but you're definitely welcome to talk to me about it after, and I would love to give you my information, because it is so possible. So the challenge is for you as a lymphedema therapist, and no, that is not me. It's Alex Honnold. If that were me, I'd be dead, because I'm scared of heights. But I love the idea of this, of the challenges. Basically, if you can climb El Capitan without a rope, anything can be done. That's more significant than going to the moon, practically. So anyway, the challenges for you out there is the length of time to treat a lymphedema patient. You're not governed by any time. You can see a patient for 30 minutes, or you can see a patient for 3 hours. So that's cool. I spent a lot of time with my patients. I spent 2.5 hours on a patient, you know? Average time I spend with a patient is 1 hour and 15 minutes, 1 hour and 10 minutes. You can kind of spend more time in the beginning and lessen it down. The problem is you got a long way to go. If you've got 6 patients in one day and you've got 30 miles between, you've got to manage your time, and that can be difficult. You don't have a control of where that referral is coming. I don't know Denver geography very well, but I'm sure you can have a 45-minute drive from one side to the other. That's the way it is in Jacksonville. And you don't have a control. If you're going to accept a lymphedema patient, if you accept that patient, if the agency accepts that patient, you're responsible. And so, you know, you can have patients that are pretty spread out. So that is a challenge. Didn't bother me. I don't mind driving. And like I said earlier, discharge planning can be very difficult, and your visits they're not necessarily numbered, but you have to control it, because episodes spiral out of control, and finances do too, and it's a big deal to the agencies. The benefits, though, this is your opportunity to open up a new world of lymphedema. This is such a big opportunity. Home care is so huge. And all these fleaball lymphedema patients, all the Medicare beneficiaries that are going to happen over the next 30 years, if we don't do something about this, if we don't get more people in home care, these patients aren't going to get seen. That's bad enough. And these home care companies, they don't necessarily want to provide this service. We can't let that happen. I don't think we can let that happen. I don't think we should. I think we need to continually challenge this part of healthcare. 20% of these people going into this service, skilled nursing facilities as well. This is a different type of lymphedema. This is a different world of lymphedema. But there's so many of us. We can take this on, and we need to. So I think for you, this is an opportunity. This is a huge opportunity. For those of you that are already in home care, you could develop a program. I developed a program. I hired 25 lymphedema therapists. And we covered a huge geography, and we had over 100 patients a day of lymphedema patients alone that we were treating. Those patients would have never gotten seen if we didn't have that. And the program's still going. So I challenge you to look into this type of healthcare, this division of healthcare for lymphedema. So here's how you be successful. You've got to be successful for you. You've got to be successful for your agency, and you've got to be successful for your patient. Not easy. And you do have to have realistic protocols. On average, you can do a 3-week, you can start off with a 3-week, 3-time-a-week frequency. And you're going to have to trim that down. You're going to have to, but I want you to remember what type of lymphedema we're treating. Phlebo lymphedema, like I told you, that's a game changer. And I'm going to tell you more about that in a minute. But you have to, the other thing is, with home care, all the therapy disciplines are all equal. OT, PT, and speech. If all 3 of them are in, and you're allotted, let's say, 20 home care visits in 60 days for rehab, if PT goes in, whatever visits they do count in that number. OT is going to count, and so is speech. If you get all 3 of them in at once, you could have 20 visits done in 2 weeks. And you still got, you've got a 60-day episode, and you've used up all your visits. So I always taught people, and those of you that are in home care, teach your agencies to prioritize. What's the most important thing here? Is the lymphedema the most important? Is there a wound? Is there an infection? If so, you're the priority. If there's a fall risk, and it's because of lymphedema, you're the priority. If there's a fall risk and the lymphedema is not the reason, then that fall risk needs to be taken care of first. Anytime you can discharge a patient to outpatient, that is a good thing. Home care agencies and outpatient companies love that. We should be utilizing each other. You don't want to keep a patient in home care longer than you have to. The idea is to discharge to outpatient. Get these patients well enough. You don't have to complete their therapy. You need to get them to an outpatient person, if you can. And I always combine phase 1 and phase 2 right from the beginning because I know time is not on my side. I'm educating on the discharge plan right from the beginning because if you don't plant it in their heads from the get-go, then it's going to catch them by surprise. You need to get that caregiver ready now because it could take you a whole month to find that person. So I always combine everything I can at once. They ask the questions, I give them the answers. And usually I find that patients ask the questions, well, what do I do when this is all over? That's a day 1 question for me. So I jump right into it. So you also want to set appropriate patient expectations. And what I mean by that is we're trying to improve function, okay? I am definitely tracking how much of a reduction I get, yes. But really what I want to do and what Medicare wants to see is what functions are you improving? Really, that's what we should be looking at anyway. Can you get shoes on? If you can get shoes on, you're going to have better balance. Your mobility is going to be improved. How long does it take you to get to the commode? Is your lymphedema getting in your way? If we can reduce that lymphedema, can the patient transfer on and off the commode easier? Those are your goals. Those are what you're doing. So you're asking the patient, with this lymphedema treatment, how can we help you in your life? And they're going to say, well, I wish I could get a pair of shoes on. I wish I could ambulate better. And those become your goals, along with reduction as well. But you have to set that patient up. You're not trying to get all of this done. You're going to have to pick and choose and prioritize what your most important goals are because you're not going to have time to do all of the work, especially with the severity of these patients. So here's some factors to consider when treating lymphedema. We've already talked about some of them. The severity of your lymphedema is going to determine your success. You're going to have a lot of stage 3 lymphedema. You're going to have a lot of obesity lymphedema. You're going to have a lot of wounds. The severity of your lymphedema is going to affect, 1, your visit frequency, how long, and your duration. How long can you see that patient? The length of the visit, if you can spend that quality time with that patient, you're going to have a better outcome. Obviously, if you've got a patient that has a lot of comorbidities, you can front load your visits. There are times when you need to see your patient 4 times in a row or 4 times in that week and give them that Wednesday off. You have to front load those visits because they do have other comorbidities that are precautionary comorbidities. They're not necessarily contraindications, but they're precautions, and you need to take that into consideration. But then you also have to be knowing what your future's looking like. How can I trim this patient down? Where can I bring that caregiver in? And can I bring that caregiver in sooner? So this is interesting. I don't think I need to talk much about lymphedema here. We understand what lymphedema is, and they're really the four categories: oncology lymphedema, primary lymphedema, phlebolymphodema, and lymphatic filariasis. These are all components of lymphedema, the high protein, the structural damage. But there's also something else we need to talk about, and that's edema. And we need to differentiate this, and it's not easy to do because a lot of these patients have CHF, and they have chronic kidney disease and high blood pressure. And these all cause edema, not lymphedema. So in the home care setting, if you're lucky enough to have a patient with just oncology lymphedema, good. Go to town. Do what you know best. Do your thing. Same with primary lymphedema. But phlebolymphodema is a little bit tricky. And it's not the lymphedema itself that's tricky. The lymphedema is actually easier to treat than these other two categories, believe it or not. And I'll tell you why in a minute. What makes phlebolymphodema hard is the fact that it happens to the elderly. And the elderly don't just have phlebolymphodema, they've got heart failure with it. It's not acute, it's chronic, and it's stabilized. So you can still treat, but you gotta be careful. You gotta know what you're doing. Chronic kidney disease, same thing. We used to turn these patients away. In the home care setting, something's gotta be done for these patients, and you gotta know how to control what you're doing and go slowly and prioritize. So that is the thing about phlebolymphodema. You don't just get to see it by itself, you're gonna see it combined. The apple and the orange are gonna be together. And this is what it looks like. Now, I'm sure everyone in here has seen these patients in outpatient. And I'm sure you've seen them in home care too, because that's what they look like. This patient's homebound, this patient's homebound, so is this patient. Maybe this patient is too. Could go either way. But this is what you're seeing. Yes, I can see the vein disease, but I can also see the obesity, the diabetes, the chronic kidney disease, all attached with it. You've got a patient with cerebral palsy, dependent position all day, lack of calf muscle pump. What's going to happen? The veins are going to go. And what's going to happen after that? The lymphedema. So this is the challenge. This is home care. And here's why phlebolymphodema can be a little bit of a game changer. Phlebolymphodema versus cancer-related lymphedema. For the MLD, when you've got phlebolymphodema, have lymph nodes been removed? They haven't been removed. The lymphatics were working just fine until they got overloaded. You're working against the vein disease, and you're working against your lymphatic components as well. The lymphatics are definitely compromised, but there is no lymph node removal. So we can focus on decongestion of the, we can focus on supraclavicular, we can do deep abdominal breathing, but we can utilize the natural lymphatic pathway for these patients and inguinal lymph nodes. That's kind of a time saver. Now, if you want to go all the way up to ipsilateral axillary lymph nodes, you're welcome to, but you don't need to. You can go to inguinal lymph nodes. Decongest the core, bring to inguinal lymph nodes, utilize your popliteal lymph nodes, and you can make it happen. And that's a big time saver. With bandaging, you see a lot of patients that are bandaged to the knee. No, that's not ideal. It happens a lot because a lot of what you're doing is vein disease, and a lot of that vein disease is below the knee. This is a habit from wound care, and sometimes it's hard to change because if you look at this patient right here, wheelchair bound, the likelihood of you being able to bandage up above that knee is low. And the success rate is also lower, and what you're really trying to do is get this patient in good footwear to balance, to improve functional mobility and transferring. So you're prioritizing. You get that patient transferring better, maybe they can get to outpatient to finish the job. But I know you've heard me talk about the frequency, and I utilized adjustable Velcro compression a lot in home care. Why? I want to utilize adjustability. I need adjustability because I know that 5 days a week therapy is ideal. That's our protocol. And if I can't get it, I need to readjust my compression. So I utilized adjustable Velcro compression whenever I possibly could, just so I could get that daily refitting of compression. And here's a study about that. We listened to a study last night on bandages and the reduction of the pressure just in a few hours. Here's another one. Day 1 with inelastic bandages, that's what IB is, inelastic bandages, 13% reduction. And adjustable Velcro compression had a 19% reduction. Over a 7-day period of time, we have a 19% reduction with inelastic bandages. Adjustable Velcro compression, 26%. Obviously, if we could bandage every day in home care, these numbers could match up. We don't have that ability. So I utilize adjustable Velcro compression for the reduced frequency so that I can get that consistency that we all talk about and need for these patients. So this visit frequency can work. This is how I provided awesome CDT in home care. 3 times a week for 1 week. I can do it 2 weeks longer. If I have to front load because I've got someone with specific comorbidities, I can do that. You do have freedoms in there that you can play with. And here's the discharge plan. We're going to discharge this patient to outpatient because now they can transfer, they can ambulate, they can get in and out of their car. Now they can make it to home or to outpatient. A couple little tips for you, those of you that are doing home care. I always carry a stool. This is literally my bag that I use for home care. I stuff it with all my goods. I wheel it in, and I always use the kneel pad. You're not on a table. You don't get that nice stool, table, or whatever. No. You're like this. And anyway, you can break your back pretty easy. So take care of your own body while you're doing this. Stool helps. And I'm going to close with this. Who's ready to jump in to home care? Did I make it sound good? Thank you very much.